تعريف كلمة تراكيوباريشيا وبرونكوماليشيا. الترم ده اتغير دلوقتي بقى اسمه major airway collapse. فاحنا هنستخدم كلمة major airway collapse better than the usage of the term tracheomalacia and bronchomalacia. For sure, the term malacia means softness and in medical terminology refers to cartilage or bone. So tracheomalacia, which is the old term, now it is means that it is weakness of the trachea to maintain an adequate airway because it is softer and becomes more susceptible to collapse. So both tracheomalacia and bronchomalacia definitely was under-recognized in the past and until now. Although there is an increased awareness of the clinicians and about the techniques of diagnosis of bronchomalacia and the tracheomalacia, I think that still we are under-diagnosing these issues a lot, especially in our country. There is no actual incidence worldwide about the term tracheomalacia and bronchomalacia, but if we can take one study, for example, that they find about 15% of cases of while they are doing bronchoscopy, tracheomalacia and bronchomalacia was representing about 15% of these cases. But this 15% raised to 30% of cases if the indications of bronchoscopy was respiratory distress. So the term tracheomalacia and bronchomalacia was seen frequently for any bronchoscopist. Whatever the indications, if the indications are severe respiratory distress, definitely this incidence increase much and raise may up to 30% of cases, which is a very high percentage. Definitely that the mortality rate from severe tracheomalacia is very high and may reach up to 80% of cases. And this is associated also with substantial morbidity and mortality. And if I said that many cases of tracheomalacia, depending on the etiology, whether primary or secondary, may be associated with other congenital malformations. The site of the majority of cases of major airway collapse, as we see that are intrathoracic airway narrowing or intrathoracic airway collapse, especially during inspiration, where the intrathoracic pressure exceeds much the intraluminal pressure during expiration, and so they are responsible mainly for extra or expiratory sounds, maybe wheeze or stridor, depending on the site of obstruction. And less commonly, the site of narrowing or the site of collapse may be extrathoracic, and this occurs almost always during inspiration, due to the affection of the extrathoracic airway by the negative intraluminal pressure, intrapleural pressure, as a reflection, as at the site of the reflection of the pleural. We have two main classification of tracheomalacia. It may be primary without known etiology, it is not an iatrogenic, it is not secondary for anything, and we have idiopathic tracheomalacia, and also we have tracheomalacia which is associated with prematurity, and this is term, I think that most of the neonates, most of the neonatologists are acquainted by these sounds which may be associated with patients, especially the preterm babies. Also, the innominate artery sometimes may cause compression in front of the trachea and causing airway collapse in addition to the vascular ring, but the vascular ring can be considered as a secondary type. We have some of the congenital anomalies, especially tracheoesophageal fistula, may be associated also with tracheomalacia, and we have certain syndromes like mucopolysaccharidosis, CHARGE, trisomy 21, and Dijor's syndrome may be associated with tracheomalacia. As regards the secondary cases of tracheomalacia, which is maybe due to prolonged intubation, especially if we are using intubation for a long time, or using inappropriate size of the tubes, or the movements of the tubes are moving in a pistol shot like movements inside the trachea, or frequent intubations with the patients, all these may be associated with tracheomalacia in some of the cases, especially if the duration is prolonged. Also, tracheotomy, if for a long time, may lead to also associated with localized tracheomalacia, because tracheomalacia or major airway collapse may be localized to one or two segments of the lung or may be generalized. In case of tracheotomy, the tracheomalacia or major airway collapse is almost always localized to the site of the tracheotomy or tracheostomy, and if it lasts for a long time, I think that it is one of the causes of tracheomalacia. Also, recurrent severe infections of the trachea bronchial tree. As we said before, preterm babies, especially with respiratory distress syndrome, because they are susceptible for infection, for intubation for a long time, and also for tracheostomy, it may be something like that, for mechanical ventilation for a long time. So all these factors together with immaturity of the cartilage cells at that age, all these factors help the development of major airway collapse. As regards these issues, in which most of the bronchoscopists deal with, we can find here that extrinsic compression of the trachea due to outside compression is the most common finding which is seen in our practice, like skeletal deformities like pectus excavatus or deformities of the chest, vascular ring, goiter, tumors, cyst or abscess. All these factors may causing compression of the trachea and causing definitely major airway collapse. We have also an incorporated histopathological and endoscopic classification of major airway. We have type 1, as we said, that which is the primary or the idiopathic one, which is congenital, as it occurs in preterm baby tracheoesophageal fistula or mucopolysaccharidosis, which is mostly the primary types. Type 2, which is tracheal collapse due to secondary compression, which is the most, also it is common in practice, which is due to secondary compression due to vascular ring, cyst, tumors, goiters, thymus enlargements. Or the last one, which is the least one in incidence, which is due to prolonged intubations, recurrent tracheobronchitis, and tracheotomy. Also, we have an associated conditions like congenital malformations. So we may get congenital heart disease in a great percentage of cases. Also, we have gastroesophageal reflux, which may be the cause or may be associated finding in also in a good percentage of cases. The symptomatology of major airway collapse definitely have a list of the manifestations. So all these findings, like stridor, like rattling, like barking cough, like wheeze, like respiratory distress, like recurrent infections, like anoxic spells, like bradycardia, like tachyarrhythmia, like breath-holding spells, like failure to drive, like respiratory distress. All these issues are seen in practice, and sometimes we may get difficulties. It could be considered as one of the causes of stridor. It considered as one of the differential diagnoses of wheeze. It is considered as one of the differential diagnoses of all of these symptoms. So it is difficult in practice to justify, and you should be acquainted about a major airway collapse as an important finding to be considered in the differential diagnosis of any of these findings. And now we are trying to see some of the cases, in short, to know that stridor, which is commonly faced in practice, especially in pediatricians, we can see such case. This is an infant with stridor. Most of the pediatricians deal with this case as a case of what? As a case of laryngomalacia. And this will improve by time. This is most of the concept of the pediatricians when he deals with stridor in infants like that. He told him that, or he told the parents that this patient has laryngomalacia and this is simple and it will improve by time. And actually that's not true. This is the X-ray of the patient, which is normal. CT, nothing can be seen here. And this is the bronchoscopy of the patients. We can see here definite tracheomalacia. And this is the CPAP because the patient was suffering a lot from this stridor. We have also another example. This is the X-ray of the patients, and this is the bronchoscopy of the patients. We can see here, this is the trachea, and we have marked compression and collapse of the tracheal lumen, as we see here, and this is the supracardial. So we have marked collapse of the trachea due to outside compression. This outside compression is due to what? Is due to vascular compression, and the patient has right side aortic arch with aberrant subclavian artery, and the trachea is compressed between the arch of the aorta, the subclavian artery which is passing behind the trachea and the esophagus. As we see here in the virtual bronchoscopic pictures, we can see here marked tracheal narrowing, as we see here. We have another case with we can see here marked tracheal narrowing with kissing anteroposterior wall of the trachea, and this means that we have marked compression on outside from the trachea, and this is due to which is something which is uncommon to us, the term innominate artery compression syndrome. The innominate artery pass just in front of the trachea and causing marked compression of it, and this can be easily corrected by aortopexy of the patients and making a stitch from this and to fix it to the sternum from outside. This is one of the examples that the innominate artery compression syndrome, which is considered as a primary type and can also be considered as secondary type of major airway collapse. Sorry for that, but this is also a newborn baby.
اكتر حاجه اللي خوفتكم اللون الازرق جامد قوي اكتر من مره وكان بيروح نفسه مش كده؟
Definitely with this, an infant which is 3 days old, suffering from stridor since birth. Normally, newborn laryngomalacia, it never be present or extremely uncommon to present day 1 or day 2. So laryngomalacia, it never be seen in most of the cases at day 1 or day 2 or day 3. It takes few days, even weeks to start with. So once we have a newborn with stridor, definitely we have a pathology, whatever this pathology is mild or moderate. But this patient, although he's 3 days old, he has severe stridor, and this stridor is associated with cyanotic spells and cyanosis. And so he's referred to me. He was referred to me due to that he has stridor, and this is the bronchoscopy for the patients at that day. So day 3. We can see, I'm sorry that it is not colored because there is some, this is the trachea, subglottic region now, and then we can see the anteroposterior wall are stick to each other, and I'm trying by the bronchoscope to separate between them for a long distance, say till we reach now the supracardial region. So we have a long segment of the trachea with anteroposterior wall kissing each other for long distances. This means that بعد إذن حضرتك ما ينفعش تتكلم وأنا بتكلم. So for a long distance, so we have something compressing on the trachea from outside. For this long distance, it is somewhat difficult for any vascular malformation to compress like that. And it is uncommon for an neonate period, an neonate infants for 2 or 3 days to get a mass like that. So we can see in the 3-dimensional reconstructive picture of the lung and the trachea, we can see here that we have no trachea here. You can see this picture. We have no trachea. Why? We can see more in later on. We'll see. We have here a thymus, a thymic shadow, which causes compression of the trachea. This is the esophagus, and the trachea is just 2 spots of air. So it means that we have a thymic shadow, Thymic mass causing compression of the trachea for a long distance, so we have no any other options except one of two. Either to do tracheostomy for the patient, and we don't know what will happen later on and for how long to be inserted, or to do thoracotomy and removal of the thymus, and this is definitely the thymus after removal, and this is the post, and this is the clinical, this is the histopathological report, and this is the child few months later after this one. So we have another case also with example to focus about that we have not just tracheomalacia. Sometimes we may get isolated bronchomalacia. It is not so common like tracheomalacia, but bronchomalacia may be less common than tracheomalacia, and we may get either isolated right or left. I think that this is one of the, we are excluding any other possibilities like chronic infection, like vascular compression from outside. So we did CT angio for that patients, and we are excluding that we have an outside compression for such patients. This is also a patient with anoxic spells, representing with severe anoxic spells that we said dying spells, which is very serious problem that for any pediatrician who see it should consider this is seriously. If it resembles, it is similar to breath holding spells, but it lasts for a long duration, and sometimes the bit may get cyanosis, and they may get convergence from this cyanosis, and in most of these cases we can see here tracheal compression, marked tracheal compression and tracheal collapse, and this is the virtual bronchoscopic picture, and this is the CT angio. We can get double aortic arch that can compress the trachea and causing this manifestation. I'm trying to express this infant. I like this case a lot because we can see here sound. Yes, it looks like stridor, it looks like rattling. I prefer the term rattling in such condition because it is not definitely a stridor. It is rattling sounds. But we can see something here. He has pectus excavatum, which is not severe, but it is moderate to little bit, but the patient is also has failure to drive. So this is the bronchoscopy for that patient, and then we are going to the left now main bronchus. What we can see here, this is the left main bronchus. Yes, it is compressed. Yes, it is compressed. The left main bronchus is compressed. Mostly this compression is due to vascular compression. And we can see here that I'm so sorry that I cannot. So this compression, what you can expect from this compression, we can get here that the pectus excavatum causing what? Causing shift of the heart to the left side, and this compressed heart to the shift light to the left side causing compression of the left main bronchus. Sometimes we cannot imagine simple procedures which is daily seen, like pectus excavatum can cause compression of the heart or shifting of the heart, and this heart shift can cause marked compression of the left main bronchus, and the patient presents with sound like that. This sound is due to what? Accumulation of secretion distal to the site of obstruction. So the rattling sounds is due to accumulation of secretion distal to the site of obstruction. In order to diagnose major airway collapse, I think that we are in need to do many things. First of all, the history of the patients, and to be also medically minded that we have a term known as major airway collapse, whatever tracheomalacia or bronchomalacia. And then pulmonary function may help you much in older children, that you can differentiate between upper airway obstruction and lower airway obstruction. So pulmonary function testing may help a lot Also, the radiology sometimes may help to differentiate some of the differential diagnosis like tracheoesophageal fistula by using barium upper GIT studies. Also, fluoroscopy sometimes may help you much for that. Also, the multi-detector spiral CT may help you for, and especially with CT angio, for something like CT angio for cases of vascular ring and sometimes with cases of tracheal stenosis. But the dynamic situations of the airway collapse in primary airway collapse, I think that it is so much difficult for any radiology to detect it, so you are in need to do bronchoscopy for such case. And so bronchoscopy is by far the most important issue for diagnosing major airway collapse. And then you can use any of the other tools to justify the proper cause for this airway collapse. As regards the treatment, medical therapy sometimes may be helpful, and sometimes the tracheotomy tube, especially elongated tracheostomy tube, may be helped. CPAP sometimes in some cases, as in case of primary airway collapse that we seen in first case, we use the CPAP in severe cases of tracheomalacia. I think that it saved life in a considerable number of patients. Aortopexy, as we see in innominate artery compression syndrome, I think that, and a lot of other issues. External splinting may help in some cases, but it is a difficult procedure, and I think it needs finest ENT doctors in association with cardiothoracic surgeon. And the last is internal tracheal stent placements, which is now progressing and increasing, but we have some difficulties in pediatric age because of the different sizes with the different age and the growing child and the type of the stent and so on. And thank you a lot for this, for your
we have time for questions. Any questions for Professor Nader?
Tracheomalacia, the collection of these cases. Vascular ring is very common. The awareness of the doctors are very common. We are seeing vascular ring. I think that every month we can see a case of vascular ring. Tracheomalacia is very common per se, the primary type, especially premature babies. Maybe I am a referral personnel, so I see a lot of cases, so I'm acquainted in every patient that came to me that we have, especially stridor in particular. You should consider stridor in particular is a very serious problem because I discovered a lot of these cases from just the term stridor. Once we have a stridor, we should clarify that not all cases of stridor are laryngomalacia in pediatrics. Stridor, laryngomalacia represents before about 65% of cases, now regressed till 50% of cases and 40% of cases. Although laryngomalacia is by far the most common, but we have at least in 40% or 50% of cases either associated malformations or other pathology. So you can consider you are missing in each one you see, in each two you are seeing in your practice, one with pathology. If you consider, if I see 10% of stridor per month, yes, you are missing 5 of them with another pathology. So to that level, we are losing a lot. Some of these issues are mild, and some of them are considerable, which may need for surgical interference like double aortic arch or whatever the situation, sometimes mass or sometimes a lot of other pathologies. I didn't give example for everything, and just to give a sample for some of the pathologies, but we have a list. If you attend the workshop of bronchoscopy, you can see what are the, for pediatrics, you can see for each title how many cases that can be present, and I think you can feel that it is not common, but not uncommon. Benign tumors, I have 5 cases of benign tumors. Yes? You see it? I have 5 cases will be presented now. Tracheal tumors. I have 5 cases and I will present them now in the pediatric. But benign tumors in particular, or tumors in the trachea, it is extremely rare possibilities. So we should not consider tracheal tumors is a common or even uncommon, but it is a rare finding, definitely for all. But I find it because I am the referral personnel for that issues, but it is rare condition by far.
Dr. Mohammed al-Barbari.
Thank you.
I'm a surgeon. I'm interested in gastroesophageal reflux disease. And in cases of life-threatening event or the anoxic event that happened to your child, you go straight away to study his tracheal and his bronchial anatomy, and you don't go to study I think the more common gastroesophageal reflux as a cause of this life-threatening event. I mean, what's your workup in cases, if a mother comes with a history of a life-threatening event? Would you go first for the gastroesophageal reflux diagnosis, and then if this is negative, you would go to the study his tracheal system, or you would go straight away to his tracheal system?
I thank you, Dr. Professor Barbari, for your question, because this is an important and common question, because gastroesophageal reflux is put in the differential diagnosis in the mind for every doctor, whatever pediatrician or surgeon, and especially ENT doctors. They deal with reflux as a very common, and it is the major cause of most of the complaints that the patients survive. I will tell you about my experience. I am not telling from the literature point of view. Definitely, I feel that we have an abuse and overdiagnose the gastroesophageal reflux a lot in practice. And a lot of cases that we are dealing with it as gastroesophageal reflux, I feel that. And I think that some of my colleagues outside agree with me about these issues when discussing this issue worldwide. And we feel that we have an overburden for overdiagnosis of the gastroesophageal reflux from other colleagues, especially the ENT doctors, because they told us that all of the cases of the stridor are due to gastroesophageal reflux. Definitely, I found gastroesophageal reflux finding in which we have an hyperemia, severe hyperemia of the tracheobronchial tree, and even starting from the supraglottic region and the epiglottis. And when you can pass through the bronchoscope, you can find hyperemia and all through. I think that we have cases of gastroesophageal reflux, definitely, but not to that common like that. It is not so common. This is from my opinion. I am not encroaching about the opinion of any other personnel. But to my opinion, I think that it is not so common like that. Definitely, we have a variety of manifestations of gastroesophageal reflux, starting from just coughing to failure to drive and interstitial lung disease. Yes, so it may present with a stridor, presents with barking cough, it presents with recurrent chest infection, starting with till the end of failure to drive in some patients. But we should consider that we have other manifestation of the patients. So what we making me to do to bronchoscopy for that patients is the associated finding. If we have respiratory noises, which is in particular is the main target for doing bronchoscopy, like stridor, rattling, wheezes, which should be persistent, not sporadic. So if with the patient we have respiratory noise, regardless of stridor, rattling, wheeze, which is persistent or recurrent, I think that this is the main indications, and we can find with them something like that.
I would like to also comment on this concerning gastroesophageal reflux. A lot of times it is a secondary finding, and maybe sometimes it would be also wise to treat gastroesophageal reflux for 2 weeks and then follow up the patient and observe the symptoms if they have improved or not.
Many cases of stridor are present in to emergency department and was given treatment as the outpatient clinic. Is 5 days treatment sufficient to decide after which cases will be go for more investigations as regards CT or bronchoscopy, or if history of recurrent stridor attacks insist on CT from the first visit?
This is an excellent question, but you should know that I'm not asking about acute stridor. Stridor that come in the emergency, it is an acute stridor, and then most probably it is due to infective process. I'm not discussing here stridor which is of acute onset, that come to the outpatient clinic with just a stridor and then improve with steroids after a few days. This is not our case. We are discussing persistent or recurrent stridor, but never we discussed bronchoscopy for acute stridor by far. Acute stridor is present every day, and it is the most common, but we are discussing the cases of chronic or persistent or recurrent stridor by far, but acute stridor, these are not the target of our case.
Some physicians, ENT physicians, advise to wait 6 months for any investigations for a case.
If he have any evidence base for this, he can tell us how he can come to this patient, which is 2-3 days old, which has a stridor. How we can wait for how long? Yes, and a lot of these patients, how we can wait. It is not an evidence base by far. Thank you. السبيكر احنا دلوقتي الاستاذه الدكتوره ماجي لويس من جامعه القاهره، وهي استاذه بيدياتريك بالمونولوجي، والاستاذ الدكتور البربري ايضا one of the eminent cardiothoracic surgeon واللي عمل شغل كويس قوي through thoracoscopic intervention to pediatric surgeon. وفي خلاف بين البيدياتريك سيرجنز والكارديوثراسيك سيرجن. He's a pediatric surgeon.
Yes. Pediatric surgeons and endoscopic surgery.
Endoscopic surgery. وعامل راو، عشان كده في طحن بين الكارديوثراسيك سيرجن وبين البيدياتريك. مفيش طحن يعني. طيب. في حالات الفاسكولار رينج انترفنشن which is I think that new for our country. Which is never touched before. فهم هيقدموا لنا دلوقتي يعني live cases for intervention of the cases of vascular ring, whatever types of vascular ring. I think then double aortic arch. Yeah.
I'm very happy to be presenting this presentation with my colleague, Dr. Mohammed Al-Barbari. And I think that the best thing that we got out of this is how collaborative work can help each other, and we can also help the patient. I'm going to start with a short introduction, and then Professor Barbari will take over concerning the case itself. Vascular compressions of the pediatric airway, I'm going to overview in this presentation. Basic laws of airway compression. How do you approach a patient with a noisy breathing? Cardiovascular anomalies causing airway compressions from a theoretical point of view. What is the endoscopic aspect from a bronchoscopist's point of view? And we're going to discuss a patient together. First of all, I like this classification very much. And it is Professor Hollinger who has put laws of airway obstruction. And if you have a patient with a noisy breathing, you would ask certain questions. And questions would include, is this noise worse awake versus asleep? So if the noise is worse, if the voice is worse asleep, then probably you are talking about a pharyngeal obstruction like tonsils or adenoids. And if the noise is worse awake and exacerbated by exertion, you would think of laryngeal, tracheal, or bronchial anomalies. And another question would be, is the noise inspiratory or expiratory or both? Inspiratory noises are usually extrathoracic, nasal, pharyngeal, or laryngeal, like laryngomalacia or bilateral vocal cord anomalies, as Professor Nader has showed us. And expiratory obstruction is intrathoracic, something that is below the vocal cords, and that includes any anomaly affecting the trachea or the bronchi, and in many ways it can mimic bronchial asthma in children. Now, congenital vascular and cardiac anomalies are characterized according to which vessel has the problem. And the first thing, and Professor Nader has showed us very interesting cases, the first thing we're going to discuss is the aberrant innominate artery. Normally, this is an upside-down anatomical view because during endoscopy or bronchoscopy, we do the bronchoscopy from the head of the patient. And you can see that the innominate artery arises more medially than it should, and it compresses the anterolateral part of the trachea on the right side. So presentations of this are characteristic of airway obstruction, like biphasic wheezing or expiratory or inspiratory wheezing, croupy or barking cough. Sometimes upper respiratory infections get a prolonged or protracted cough that really sounds a little funny. But interesting to this anomaly is that patients may suffer from dying spells or apneic attacks. It is one of the differential diagnoses of the apparent life-threatening events in the newborn, and these can be very alarming to the parents. And bronchoscopically, you would naturally find a compression of the trachea on the right side, giving it a characteristic triangular appearance as opposed to the complete round or C-shaped findings. Now, vascular rings are restricted to anomalies involving the aortic arch. And of course, vascular rings are now used synonymically with many of the other conditions, but they are characterized by forming a complete circle around the trachea. And that can be either a double aortic arch or a right-sided arch with a left ligamentum arteriosum and so forth. When we're describing a double aortic arch, sometimes the right arch is dominant, and that's in most of the patients. Sometimes the left arch is dominant, and that's less common. And sometimes the arches are balanced and both have a similar size. And again, this is an upside-down view of a double aortic arch completely encircling the trachea. Of course, symptoms usually begin very early in life. Sometimes patients are presenting at birth, but all of them will probably present by 3 months of age, and they will have respiratory symptoms, again, biphasic stridor, exacerbated by feeding or exertion, as we have discussed. And another symptom that is very interesting is dysphagia, because there is, of course, esophageal compression with this anomaly. And dysphagia may not start very early when the baby is breastfeeding, but later on, when the baby starts to take solids, this dysphagia becomes worse. Now, another interesting finding is the pulmonary artery sling, again, better upside down. And that's where the left pulmonary artery arises, makes a circle around the lower part of the trachea, compressing the lower part of the trachea on the right side and the right main bronchus. Pulmonary artery sling is also characterized by progressive respiratory symptoms. Professor Puhunik yesterday showed us a very interesting endoscopy of a pulmonary artery sling. And sometimes recurrent infections exacerbate the clinical picture. Bronchoscopy, of course, you find the anomaly or the compression restricted to the lower part of the trachea, coming on the right side, may involve the right main bronchus as well. Now, the aberrant right subclavian artery is not very common because in most cases, it may not be symptomatic. It may be symptomatic in the form of a protracted cough after a viral infection. And this can put this patient in a differential diagnosis of asthma. Congenital cardiac defects are also causes of airway compression, and they do so by enlargement of the vessels, the great vessels or the chambers of the heart. So if you have, for instance, a congenital heart disease with right to left shunts, and you have maybe a pulmonary hypertension or left atrial enlargement, then this would probably also compress the airway and give symptoms characteristic of airway compression or obstruction. Now, this is a schematic for the bronchoscopist as to if you're doing a bronchoscopy and you're looking down the airways, what you can see in terms of vascular compressions. And as we have discussed, okay, so this is the innominate artery, and this is an anomalous innominate artery compressing the trachea on the right side, giving it a characteristic triangular shape. This is further down a little bit on the trachea, maybe in the middle to lower thirds, and you can find compression from the right-sided aortic arch, giving the tracheal opening a characteristic comma shape. Going down further, a pulmonary artery sling on the right side and even the right main bronchus, and a right pulmonary artery also may compress on the right side. Congenital heart disease with cardiac enlargement or main vessel enlargement causes compression on the left side, like the left atrial enlargement here in the left main bronchus, and left pulmonary artery dilatation also as well. So basically, if you find a compression coming from the right side, this is probably a vascular compression. But if you find a compression coming from the left side, this is probably a cardiac compression. Now, we are going to discuss this case that we have worked together with a surgery. She's a 3-month-old. She has presented with noisy breathing, excessive airway secretions. She has been treated several times for repeated chest infections, and sometimes her chest x-ray would also show some pneumonic infiltrates. She would be given antibiotic treatment, but antibiotics improved her, and then the noise would continue and the infections may recur. She had no feeding difficulties. Her measurements were normal. Her weight gain was normal. She was quite healthy otherwise. And on examination, she had a biphasic stridor with a coarse scattered crepitations on the chest. I don't know if you can. مفيش صوت. ما حتى But Professor Nader has showed us many of those cases before. Basically, الصوت في الكمبيوتر مفتوح. عليت الصوت بتاع الجهاز. شغلهم دلوقتي. أنا سامعة شوية بس مش عارفة. اوكي
ندي رقم 7.
خلاص مش مشكلة. Basically, what you would hear in this video is a biphasic stridulous sound that also has the noise of secretions in it. And so we did the bronchoscopy in the evaluation of this patient. And to be honest, this was not the first investigation that we did. مش بيشتغل خلاص مش مهم الصوت، ممكن نشغل الفيديو ده. So this is the bronchoscopy for this patient. Going down the tracheal membrane. And you can see there is an anterolateral compression, more in the lower part of the trachea, giving it the characteristic comma-shaped or paisley-shaped trachea. Basically, the compression in this patient is from the right side. So the compressing part of the aorta is the right-sided aortic arch. Okay. خلاص؟ Okay. So لسه البرزنتيشن بقى. لسه في الاسوفجس. ده برضو على نفس ال final one. ممكن قفلته بس مش مشكلة، ممكن نمشي. We proceeded during bronchoscopy to do also an esophagoscopy. And basically that was in the same session. Sometimes when doing pediatric bronchoscopy, we can run down the esophagus as well. We don't see it very well like the GI endoscopists do, but we can also see that there was a pulsating compression of the esophagus. Now I will, okay. Now I will leave the rest of the radiological interpretation to my colleague, Professor Mohammed Al-Barbari.
شكرا.
انا اسمي محمد البربري، انا جراح اطفال يا بيه، مش انا جراح اطفال مش cardiothoracic surgeon. I'm a pediatric surgeon, and we happen to do a lot of chest surgery because we do a lot of laparoscopy. We deal with diaphragms, we deal with tracheoesophageal fistulae. Now we're doing it laparoscopically. We take lung biopsies because once we offer the service of laparoscopy or thoracoscopy, better said, to the pediatric doctors, then they're much happier with the outcome. And this is the tip of what we've done. We're very proud of doing this case. This is the first case that we've done thoracoscopically to divide an aortic arch. And this was after like 6 years experience with thoracic surgery, thoracoscopic surgeries done thoracoscopically. This case presented at age, as Maggie said, of 3 months. And after we've done the investigations that she said, the bronchoscopy, we've done a barium swallow and actually an omnipaque swallow. As you can see, there is a persistent narrowing of the esophagus because of the indentation done by the aortic arch. This is the CT reconstruction of the vascular anomaly that she had, and we can see that she had 2 aortic arches causing compression of the esophagus and the trachea. We've completed it with an echocardiography that showed no intracardiac lesions, and then we proceeded to surgery. This is an animation done by, actually, I would like it very much to show it to you. فين الفايل? Because this would show you actually the actual anatomy as it rotates. This is the ascending aorta going into right and left branches, and then completing the circle from posterior. You can see it as going down to the descending aorta. This is the descending aorta, this is the right, and this is the left arches, and this where the esophagus and the trachea should have been, they're taken out of the construction. This is actually the view that we're going to see in the surgery. We thought that it's better to show it to you in still first before showing you the movie. That would be the aorta coming from the heart there, the ascending aorta. This is the left limb going down into the descending aorta. That's the subclavian, and that's the right limb coming from the other side of the esophagus, and that's the esophagus there. That's what we see. And our aim is to divide this bit of the aortic arch to free this ring. That's the ring that's being done, and a right limb coming from this side and the left limb joining it going down, and that's why it is causing this compression. That's a very short movie. Of the procedure that took around 70 minutes to do. We introduce 3 ports. We use 2 5mm ports. That's one for the scope and one for the procedure. And then we use another 3mm ports, another 3mm. This is one for the scope and one for the dissection and clipping of the arch, and that's for handling the tissues. The first thing that we do is that we divide the pleural, the parietal pleura. Here we can see that's the subclavian going into the neck, and that's the descending aorta. Now what we have to do is we have to open the parietal pleura. The esophagus would be back there. I would like also to remind you again of the picture. That's the left, that's the right, and that's the descending aorta, and that's the esophagus that we aim to see. The first thing that we do is that we open, using a monopolar cautery, we open the parietal pleura, exposing the vascular structures and the esophagus, using very low current, and then we free the esophagus of the we free the esophagus from the aorta on both sides. Okay, that's the esophagus there. That's the esophagus here, and that's the bit that we want to divide. Okay, now you can see that's the first time that that's the right side coming here into view because it's coming from the other side. Okay, and that's the esophagus, and that's the recurrent laryngeal nerve that we should take care not to divide. And then we continue dividing the esophagus by blind dissection. I think you can appreciate now the view of the compression. That's the right, and that's the left side again. Then we go from behind the esophagus, the left arch, put a vascular tape around it, make sure that it's all taken off the esophagus, and then we clip it. Then we apply, these are 3 5mm clips that we clip the vessels with it, and then we divide them. Here's the first clip being put on at the side of the descending aorta, and then we will apply 2 more towards the ascending aorta, and then we would divide the vessel. Here are the 3 clips in place, and that's the esophagus passing from behind. After dividing this, you would see that it instantaneously springs back, and the esophagus come into vision. That was the most terrifying time dividing the aortic arch. This was really very stressing at that time. Now, I would like you to appreciate the spring back that would happen now. Okay, you can see it came back to place, and the esophagus was freed. She spent as we told you, it was uneventful. We finished it in 70 minutes. There was no apparent post-operative complication except for some residual post-operative chest infection that has cleared in like 10 days, and then she was discharged. Thank you very much.
Any question, please, for Professor Barbari?
Deal with patent ductus. I've never done a patent ductus thoracoscopy.
Sometimes you have some cases, definitely.
Yes, sometimes we have this a complete ring. Yes, this was a complete ring. But this was a complete ring. Yes, I must say this. Yes, I understand this very well. But we had, in Cairo University, we had the pleasure or the luxury of working in collaboration with a very clever CDD radiologist, Hassan Kiki. He's very clever, and we studied this anatomy thoroughly before going in.
But definitely some cases of double aortic arch may be associated with definitely PDA, but in this case he be sure that he have no case of PDA. Yes. Yeah. Yes. We have double mirror image, or we have atretic band on the right side, and especially on the right side we have atretic band, which is more easier than this. Yes.
Actually, it's much easier dividing an atretic band rather than dividing an aortic arch. And in this case, it was actually both 70% of the arches we would have a dominant right side, 20% we have a dominant left side.
Yes.
But in this case, they were almost equal. And we spent a lot of time discussing whether we should divide the right one or the left one.
Yes.
Thank you.
Many thanks. Any question, please? Because time is now just for the next session. No question? Thanks a lot for Professor Dr. Barbari, Dr. Maggie. Many thanks for your effort.